I'm a PG from AIMS and I've done my senior residency as well there. So please listen to me carefully when I speak about the patterns that we are talking here. Good evening, everyone. Yeah. So what I have compiled now, you can look at it. I have compiled. Just a minute. Yes. So I have compiled the topic from where it is coming. And for INICET topic, hematology is a very important. And for INICET topic, hematology is a very important. And for sorry. Yeah. So hematology is a very important topic for INICET. Good evening, everyone. So let me start with this now. Look at this previous year topics. I want to just you brush up you what is happening in a. So I'm talking previous year topics in hematology. I've divided them into various topics and I've labeled what years when where they asked. And you can see here, look what is happening. Commonality. What I'm saying, that topic is getting repeated. This topic is getting repeated. This is also getting what? Repeated. This is also getting repeated. Are you seeing these topics are getting not only this, even previously also. Once the topic comes, they will get repeated for what? 2 to 3 years on that topic. You can see. Okay. Yes. So important. And so I have divided it for what? RBC, WBC, platelet and transfusion medicine for these about what? Hematology. So let us start with first in hematology then. So in hematology, I'll start first with the WBC disorders. So in hematology, WBC disorders, पहले क्या पूछेंगे? Okay. So previously, what have been asked based on that, I'm going to predict. Yes, in this first genetics of lymphomas, important question. Genetics of lymphoma, important question. अच्छा क्या होगा? Genetics of lymphoma, important translocation. So what are the important translocation? Translocation 2-5. This leads to protein called ALK1. Can anybody tell me which lymphoma? It will be used as one revision as well. Translocation 2-5 leads to what? ALK1. One more translocation 2-8. Expect this always. 2-8, 8-14 and 8-22. 8-22. So these will lead to c-MYC proto-oncogene mutation. Which lymphoma am I talking? Third one, translocation 11-14 leads to cyclin D1 proto-oncogene. Cyclin D1. Then fourth one, translocation 11-18. This can sometimes leads to BCL2 production. Then fifth one, translocation 14-18. So important, these are, okay, this will produce what? BCL2. Yes, sir. Tell me the first one. Where do you see? Very good. The first one is ALCL, correct? Anaplastic large cell lymphoma. Anaplastic large cell is which type of lymphoma? Anaplastic large cell is which type of lymphoma? It is a T cell lymphoma, isn't it? Anaplastic large cell is a T cell lymphoma. Then this will be in Burkitt lymphoma, correct? So question can come either the protein or even what? Yes, Burkitt is what type? It is a germinal center origin B cell lymphoma, isn't it? B cell NHL. Next, translocation 11-18 seen in mantle cell lymphoma. Mantle cell is also B cell origin. Foot 11-18 will be seen in marginal zone. Marginal zone and maltomas. Marginal zone, maltomas. Then 14-18. This will be seen where? 14-18 will be seen in follicular lymphoma. Follicular lymphoma. So these are important lymphomas. Few more let us add to this. BRAF mutation. Tell me, where do you get BRAF mutation? Seen in hairy cell leukemia. Translocation 922. Where do you get translocation 922? This leads to what? Tyrosine kinase. Also called as what? Philadelphia. Tyrosine kinase. Then one more, JAK2 mutation. Where do you see JAK2 mutations? Yes, sir. So BRAF 922 translocation seen in CML. JAK2 mutation will be seen in polycythemia vera and also essential thrombocytosis. polycythemia vera, and essential thrombocytosis, JAK2 mutation. Then few more. Let me write these important translocation. Importance of them. Tell me translocation 821, translocation 1517, and inversion 16. What is the importance of these? Inversion 16. Important. These three translocation are diagnostic of AML. These are diagnostic of AML even without, even with, I would say, even with less than 20% blast in bone marrow. So even if there are less than 20% blast in the bone marrow, these will be what diagnosed as AML. Because of these what genetics, they will always be diagnosed as AML. Okay. Next, another important topic in WBC, they will ask you another important topic in WBC, which has been asked previously repeated number of times, and that is why I want to discuss that as well. Yes, sir. So another important topic is diagnostic criteria. Few of them. Okay, one, diagnostic criteria for AML. Diagnostic criteria for AML. What is the diagnostic criteria for AML? There are two criteria. One, blast should be how much? More bone marrow in bone marrow. Blast in bone marrow should be more than or equal to 20%. Or another criteria, any of the genetics translocation 821 or translocation 1517 or inversion 16. So any one of these genetics, irrespective of what? Irrespective of genetics. So this will be irrespective of blast. Irrespective of blast percentage. So this, the second criteria is irrespective of blast percentage, right? Yes. So that is for now. What is the diagnostic criteria for CML? Tell me, what is the diagnostic criteria for CML? For CML, diagnostic criteria, only one criteria. What is that? There should be translocation 922. CML diagnostic criteria is 922 translocation. Important, expect this also. 1517 translocation will be predominantly AML, M3 or APML, acute promyelocytic leukemia. And what is the treatment for this condition? All trans retinoic acid. All trans retinoic acid plus arsenic trioxide. Arsenic trioxide. Okay, expect this ATRA as a question, plus arsenic trioxide. Okay, yes. Now next is translocation 922. For all genetics, obviously, all cytogenetics, first investigation will be what? Fish. Isn't it? Yes, first investigation will be what? Fish here, right? Next. Now, next is one more, markers. CD markers, they will give you approach to CD markers. See, there will be, definitely there will be 4 question minimum coming in your one from WBC topic. And there have been variation of questions. Sometimes there have been what? 8 to 9 question coming from WBC in one of the INICET. So that is why you should be CD marker approach. So first approach, what will I look first? First look for CD3 in order. First order I will write. What all will you look for? First we will look for CD3 and 20, both of them. After that, look for CD5. After that, look for third marker CD10. After that, look for CD23. 5, 10, 23. Right? Yes. So this is how I'll be looking. So first look what? 3 and 20. Then look 5, 10 and 23. Or you can exchange 10 and 23. No problem. Okay. Now let me give you the approach. Okay. A lymphoma is, okay, first CD3 and CD20, isn't it? So if it is CD20 positive or CD3 positive, CD3 positive is a T cell origin. Then check for in CD3, you will check CD5 will be positive only because T cell. Then check for CD10. If CD10 is positive, then it is precursor. If CD10 is negative, then it is peripheral. peripheral T cell. CD10 is positive precursor. There will be what? Check for, okay, it is precursor. Check for TDT and CD34. They should also be positive. Definitely what? Precursor. Diagnosis will be what? TALL then. Your diagnosis will be TALL. Isn't it? So if it is CD20 positive, then what? Sir, if 20 positive, then I told you look for CD5 first. Look for CD5. Two possibilities with 5. Tell me what? CD5 positive or CD5 negative. CD5 positive, that means it is pre-germinal. Pre-germinal, my DDs are mantle cell lymphoma and a BCLL SLL, isn't it? Mantle cell and a BCLL SLL. Now, if CD5 negative, it is not pre-germinal, check for CD10. Now, CD10 could be positive or negative. Yes. So CD10, let me write positive here, negative here. If CD10 is negative, then check CD23. CD23. Here also you will check CD23. Here also you will check CD23. So you are checking 23 after 10. Okay. Now, so CD10 negative. Okay. 5 negative, 10 negative, 23 also negative. If 23 is a negative, yes. So CD10 negative, then what? 23 also negative, then what? Yes, sir. 23 usually will be negative. This will be post-germinal center. Post-GC diagnosis. What all will be the diagnosis? You can think of hairy cell, marginal zone lymphoma, maltoma. This is what will be my DDs. Yeah, correct. So now let me talk here. CD23 I am checking. 10 is what? Positive and 23. Two possibilities with 23 here. It could be positive or it could be negative. Yes, I'll write the other way around. Positive and negative. Now tell me, 10 is positive, 23 positive. What is it? This will be germinal center origin. 10 positive, 23 negative. This will be what? Precursor. Confirm this with what? TDT and CD34. If they are positive, definitely it is what? BALL. Definitely BALL, isn't it? Yes, sir. Now, acha, 23 is, now look at this, 23 is positive, 10 is also positive, 10 is positive, 23 is positive, germinal center. Germinal center, my DDs will be, yes, Burkitt lymphoma, diffuse large B-cell lymphoma, Hodgkin lymphoma. In this keywords, Hodgkin, okay, leave Hodgkin. Another I'll write follicular. Hodgkin is also germinal origin, but it will be CD20 negative. That's why I'm not writing here. Now, in this follicular is a low grade. Because it is low grade, you will get what? No B symptoms history and low Ki67. These two will be what? High grade. So because they are high grade, there will be what? B symptoms will be there clinically. B symptoms will be there and high Ki67. There will be high Ki67. Alright. Next, especially if Ki67 100%, then what? Then make a diagnosis of Burkitt lymphoma. Both of them will be high, but if it is 100% almost, then what? Make a diagnosis of Burkitt, isn't it? Now, on the other side, let us look. What is that? Acha, 5 positive, check for 23, I told. Now, two possibilities with 23. 23 could be positive and 23 could be negative. 23 is positive, BCLL, SLL. 23 is negative, mantle cell lymphoma. And in mantle cell, check cyclin D1 further. Cyclin D1. Two possibilities with cyclin D1. Cyclin D1 is what? Positive or negative. If it is positive, it is called cyclin D1 positive mantle cell lymphoma, which is expected. Around 15% cases will be cyclin D1 negative. This is called cyclin D1 negative mantle cell lymphoma. I expect this question now. Confirmatory marker, they will be SOX11 positive. SOX11 is a marker for what? SOX11 is a marker for cyclin D1 negative mantle cell lymphoma. Yes. So this is your approach to what? Lymphoma markers. Approach to lymphoma markers. Now next one more approach. Again I expect this approach to acute leukemias. Approach to acute leukemia. So whenever you get an acute leukemia or just leukemia, you can say approach to an acute leukemia. Yes, sir. What will be the peripheral blood smear in acute leukemia? Peripheral blood smear will be showing pancytopenia. There will be pancytopenia. That's it. Nothing more. Right? Now, correct. Investigation, we always do bone marrow aspirate first. We do bone marrow aspirate. Now, on bone marrow aspirate, check morphology. On morphology, abundant granular cytoplasm. Morphology, blast will appear as what? Large cells, whether lymphoid or what? Myeloid, both will be what? Large cells will be there. Now, if there is abundant granular cytoplasm or scant agranular cytoplasm, tell me now, what do you suspect? Scant agranular cytoplasm. Now, abundant granular cytoplasm, okay, clinically, hepatosplenomegaly will be there in both of them. So, both myeloid and acute lymphoid leukemia, there will be one hepatosplenomegaly. Yes, this is what I will suspect. What now? Myeloid. And this is your lymphoid. Myeloid, lymphoid. Now, so if it is myeloid, what do I do further? Yes, sir. If it is myeloid, what do I do? I will do cytogenetics first. Cytogenetics, that is what? Fish. Fish positive, negative. Fish positive, negative. Okay, ulta side likhta hu. This is negative, this is positive. Fish negative, do PCR. Fish is positive, then what? AML with that, cytogenetics. PCR, again two possibilities, what? PCR positive, negative. If PCR is negative, look for other causes. Look for other cause. Other causes present or absent. If it is absent, this will be called AML-NOS. Further classify based on morphology. So they can give you anywhere. So first you will do what? For acute myeloid leukemia, we will be doing what? Fish. Then what? Fish you will be doing. Then if it is negative, then do what? PCR. If PCR is also negative, then do what? Look for other causes like radiation, etc. And that is also negative. Then what? You call it AML-NOS. For that, you have to classify on morphology. For scant agranular cytoplasm, if it is lymphoid, then flow cytometry. Star mark. Flow cytometry is not used for myeloid. It is used only for what? Lymphoid. Isn't it? Yes. So, flow cytometry. Okay. Next, one more. Expect this question. Myeloid sarcoma. Exception is here. What is that? Myeloid sarcoma. Also called chloroma. This is nothing but extramedullary AML deposits. Extramedullary AML happening. So, most common site of myeloid sarcoma is gums and also what? Skin. Most common site, gum and skin. Myeloid sarcoma. Investigation. Okay. Peripheral blood smear can show increased blast. But investigation of choice, biopsy. important myeloid sarcoma biopsy करके we have to further do IHC markers. This is one condition where there is what? It is a myeloid, but we do what? Markers. Right? Yes, markers will be done. Next. So this is about the important topics of WBC. RBC, most important topic in RBC are two. Yes, what are the two important topics in RBC that will be coming in exam? In RBC, one is your what? Microcytic anemia and another is your macrocytic, two condition. So both of them are commonly asked. Microcytic DDs are what? Sita, we know that, isn't it? So approach to microcytic, most of the questions will come from here only. Approach to microcytic anemia. This flow chart they will give you. Acha, whenever you have a microcytic, first we will do what? Start oral iron. And this we call challenge oral iron. So we are challenging. Whom are we challenging? Disease. After challenging, measure retic count after 1 week. Retic count increases. कोई बताएगा क्या होगा? What is it? Retic count increases or retic count does not increase? No increase. Tell me. Retic count increases, it is IDA. What do I do next? Yes, sir. What do I do next? Continue oral iron for 6 to 12 months. 6 to 12 months. If it is not increased, then important next investigation will be iron profile. Next investigation will be iron profile. And in iron profile, what do I do? Yes, sir. In iron profile, I can say like this. In Sidro, okay, first I'll remember what? Sita are there. Okay, let us write like this. Sita. In iron deficiency, all decreased except TIBC. Sideroblastic anemia, exactly opposite of IDA. Means what? All are increased except TIBC in sideroblastic anemia. In thalassemia, it will be thalassemia minor, all normal. Anemia of chronic disease, all decreased except serum ferritin. All decreased except serum ferritin. Right? So this is how I will be looking. Other antecedental investigation, sideroblastic में क्या मिलेगा? Or additionally, sideroblastic can show peripheral blood smear, can show Pappenheimer bodies. And anemia of chronic disease can show increased ESR, increased TLC, increased CRP. Right? That will be the finding that we'll be seeing here. Clear? Yes. So this is your expected. Next, B12 and folate deficiency. Basically megaloblastic, B12, folic acid deficiency. B12 happens in vegetarians, vegans. Folate happens in those people who do not eat fruits and vegetables. Because folic acid is coming from what? Fresh fruits and vegetables, right? Next, B12 commonly vegans and pure vegetarians. Other than that, B12 causes what? Pernicious anemia also. But usually they'll give you history of vegan or vegetarians will be given to you, isn't it? Yes. In B12, important neurological manifestation will be seen. Neurological manifestation present, absent in folic acid deficiency. Right? Neurological manifestation present, absent. Next, okay, one more B12, hyperpigmented knuckles. Hyperpigmented knuckles in B12, absent in folic acid deficiency. Then increased methylmalonic acid. B12, not in. Okay, in folate, it is increase in figlu in urine. Increased figlu in urine, right? No, this will my approach is a topic based approach rather than what question based approach. Okay. Yes. So increase in figlu in urine will be seen in what folate deficiency. Next, one more important. Yes, sir. Folic acid deficiency stores last for only 3 to 4 months. Stores last only for what? 3 to 4 months. Whereas stores of B12 last for 1 to 2 years. That is why they will give you a question. Patient is having what? Some deficiency. Of course, gastrectomy will be causing what? B12 deficiency, not folic acid. Folic acid will happen due to jejunectomy. Absorption will be, yeah, gastrectomy can lead to both B12 and iron deficiency. But initially, iron deficiency because B12, this is the important keyword you should remember. If B12 deficiency is going to happen for anything, it will take minimum 1 to 2 years to manifest. So, post gastrectomy, anemia happens within 1 to 2 years, within 1 year. Don't make diagnosis of B12, make a diagnosis of iron deficiency, isn't it? Yes. Next. So treatment will be what? Treatment will be both vitamin B12 plus folic acid. Both should be given. Never give only folate. If you give only folic acid, there will be precipitation of neurological manifestations happening. Neurological manifestations will precipitate. Okay. Yes. Next. One more as usual. Next topic of favorite of examiner will be what? Vacutainers. So, what are the different vacutainers? We have discussed this so many times in DVT, in class, etc. Order. Important, they will ask you order. So, first culture bottle, then citrate, then serum tube, then serum. Basically, both of these are what? Serum tubes. Then heparin, EDTA, then ACD tube, and oxalate with fluoride. So, remember, the gray color is oxalate with fluoride. Oxalate is the anticoagulant. Fluoride is what? Glycolysis inhibitor. Fluoride is glycolysis inhibitor. So if they ask you in gray tube what is the anticoagulant, don't write fluoride. It is what? Oxalate. Okay. So this is the correct order you should be taking. Expect these two questions. Heparin, where do you use? ABG and OFT. Osmotic fragility test also we use what? Heparin, isn't it? Yes, and color coding also they will ask you. Blue, then red. Okay, serum tubes can be red. Commonly we use red, but it can be even what? Golden yellow as well. Even it can be golden yellow also. Okay. Yes. One more important question from TEG they can ask you. So this already I have discussed so many times in class, DVT everywhere. So I'll not take much time, but expect question from TEG. What does TEG determine? All aspects of coagulation. Primary, secondary clot and fibrinolysis. Now, primary clot, here only I'll just in brief I will tell. Primary clot is measured by maximum amplitude. Secondary clot is measured by R value, isn't it? R even K value also measures what? Secondary. R important, K specific. Fibrinolysis is measured by LY30. Fibrinolysis is measured by LY30. And is it a diagnostic? No, it is not a diagnostic test. It is a screening test. Usually done before what? Usually done before before surgery, right? Next, in blood transfusion reactions, important I expect Trally-Taco. Trally versus Taco. Expect this question always. How do I differentiate? Both of them will have breathlessness common features first. Okay, Trally is non-cardiogenic pulmonary edema. Taco is cardiogenic pulmonary edema. Cardiogenic pulmonary edema. Taco. Now, in Trally, by definition, it should occur within 6 hours of transfusion. It should occur within 6 hours of transfusion. Yes. And there should be no cardiac illness. There should be no cardiac illness. These have to be must. Any one of them is not justified. It cannot be one. It cannot be trally. Next, important difference clinically, BP. BP is increased in TACO. BP will be reduced or normal in trally. Even we can measure BNP investigation. Investigation, BNPs increased in TACO, decreased in trally. BNPs will be decreased in trally. Isn't it? Yes, TACO trally, important question that will come in exam. Right? Yes. So these were questions from hematology. Now, general pathology. In general pathology, important questions will come from genetics. Genetics, what all test? Genetic testing done. Okay, tests in genetics. Let me talk. Karyotype. Karyotype is used for what? Is okay. Is used for aneuploidy and yes, cytogenetics. Basically, cytogenetics means what? Can I detect translocations? Yes. And other inversion, etc. can be detected. Chest X-ray? No. Both of them will show pulmonary edema feature. Both will show pulmonary edema features. So chest X-ray cannot distinguish TACO and trally. They will give you that option also. Chest X-ray cannot distinguish TACO trally because both are pulmonary edema. Next. So karyotype. Importance of karyotype. 5 mega base pair is the resolution. Okay, we'll do one thing better. I will write what? 3 things together. Karyotype, fish, and PCR. All 3 comparison. Karyotype resolution. 5 mega base pair. Fish resolution, few base pairs. PCR resolution, 1 base pair. PCR can detect anything. Yes, PCR can detect anything. Now, for karyotype, important metaphasic arrest is required. Metaphasic arrest is must for karyotype. It is not required for other two. Next, in fish, important sequence should be known. Should be known before. That is a disadvantage. This is not required for what? Both karyotype and PCR. Even if you don't know the sequence, you can still do what? Karyotype and PCR. Now, acha, cytogenetics can be identified by whom? Cytogenetics can be identified by karyotype, fish. Even you can identify it on PCR also. But we usually don't do PCR for what? Cytogenetics. We commonly do what? Karyotype and fish. Which is more specific? Most specific test is what? PCR. Fish is also specific but not most. Karyotype is non-specific. Karyotype is non-specific. Most specific will be what? PCR. If that is why. But only thing is because of its specificity, very high specificity, it also becomes a disadvantage as well sometimes. That is why we do okay. So next is what can be mutations. Mutations cannot be detected on karyotype, can be detected on fish and PCR. PCR, all mutations can be detected. In fish, only deletions and amplification. Only deletion and amplification in fish. Deletion, amplification in fish. Yes. Next important question in neoplasia, we'll talk. Another important topic of neoplasia question will come. From neoplasia, 2 important things. One, paraneoplastic syndrome. पक्का क्वेश्चन आएगा ही आएगा. Paraneoplastic. Important paraneoplastic. Okay. Cushing syndrome. कहाँ मिलेगा? So exam they will give you what directly? A clinical history of what? A cancer, cough, and he's having Cushing's. Where do you see Cushing syndrome? Cushing syndrome commonly seen in small cell lung carcinoma, pancreatic tumor, and even neural tumors can show Cushing's. Then SIADH also seen in SCLC, small cell. SIADH will manifest as what? Hyponatremia, isn't it? Then hypercalcemia in squamous cell carcinoma or SCC, you can write squamous cell carcinoma of lung. Then other than that, RCC, breast carcinoma, adult T cell leukemia lymphoma. Expect this. Adult T cell leukemia lymphoma. Next, ataxia, cerebellar ataxia happens in Hodgkin and non-Hodgkin lymphomas. Then nephrotic syndrome also. Nephrotic syndrome also occurs in both Hodgkin lymphomas, non-Hodgkin lymphomas. Yes. Then one more, polycythemia as a paraneoplastic. Polycythemia, paraneoplastic in RCC, HCC. Too important. Pure red cell aplasia as a paraneoplastic in thymoma. Pure red cell aplasia in thymoma. So these are the important paraneoplastic. Cerebellar degeneration is the one which will lead to what? Ataxia, by the way. Cerebellar degeneration is the one which leads to ataxia. Okay. Next. Then next is in neoplasia, one more important, viral carcinogenesis. Yes, what is the function of LMP1? Activates BCL2. EBNA, function of EBNA, viral oncoproteins, these are activates cyclin D1. These are both what? EBV proteins. HPV proteins, tell me now, human papillomavirus E6 and E7. What does E6 do? Proteolysis of P53. So basically there is what? Inactivation of P53. And E7 induces phosphorylation of RB. Again, this will also be what? Inactivation. Important, EBV acts via what? Proto-oncogene. HPV acts via what? Tumor suppressor genes. So it will act via tumors. HPV is acting via tumor suppressor gene, isn't it? Yes. Next, one more in viral carcinogenesis you should know is, yes, what are AIDS defining malignancies? AIDS defining malignancy. High grade NHL. What do you mean by AIDS defining malignancy? This tells me patient is having HIV plus these malignancies, makes a diagnosis of AIDS. Immunodeficiency. No, not Castleman disease. High grade non-Hodgkin lymphoma. Kaposi sarcoma, correct? And squamous cell carcinoma of cervix. These are AIDS defining malignancy. Yes, correct? No, not esophageal candidiasis will be what? AIDS defining condition. We are talking only what? Malignancies. Condition will be many more. Cryptococcus infection, pneumocystis infection, candidiasis, all these will be what? Conditions. We are talking what? Malignancies, isn't it? Yes, AIDS defining malignancies. These are AIDS defining malignancy. Okay. Yes. Next, from systemic pathology. So in general pathology, two topics I have taken. Hypersensitivity is one more topic. Examples they will give you. And yes, we have already studied them in the class. You can. Yes. No, not Castleman. Only these three. Castleman, in fact, is considered to be a pre-neoplastic condition. Okay. So some people consider still it as what? A precursor of DLBCL. Primary CNS effusion lymphomas, no. I mean, primary CNS lymphomas will be high-grade lymphomas only, right? So CNS lymphomas usually are high-grade. So if it is a high-grade non-Hodgkin lymphoma, it will be. Okay. So Castleman, what you are talking is, some people consider Castleman as a DLBCL, diffuse large B-cell lymphoma. Some people consider as a precursor of DLBCL. Okay. Yes. So DLBCL will be considered as what? AIDS defining malignancy. Okay. Next. One more. Yes, is now systemic cardiovascular. In cardiovascular, cardiomyopathy. Cardiomyopathy, DCMP first. Dilated cardiomyopathy 2. Yes, 1. You should know what mutation. Titin mutation leads to important finding ninja star appearance. Ninja star appearance and myocyte disarray. What abnormality in DCMP? Systolic failure. Systolic failure is happening in DCMP. Then one more, a subtype of DCMP, AR, arrhythmogenic right ventricular dilated cardiomyopathy. This occurs due to plakoglobin mutation. This is a desmosomal junctional protein, and because of this mutation, there will also be epithelial abnormality like hyperkeratosis in the skin also can be seen. Yes, correct. Naxos syndrome also. Yes, various syndrome names are known. Yes, this will have right ventricular muscle is replaced by fat. Right ventricular muscle is replaced by fat here in AR arrhythmogenic. Yes, patients will die because of arrhythmias here. Usually AFib, VFib, that will be causing death in the patient. Okay. Oh, sorry. Myocyte disarray. Yeah. Thank you. Myocyte disarray is not here. Myocyte disarray will be in HOCM. We are discussing next HOCM. What is HOCM? Hypertrophic cardiomyopathy due to mutation of what? Myosin heavy chain 7. Myosin heavy chain 7. Another MYBPC. Myosin binding protein C. Yes. Now, HOCM, yes, on histology, you will see boxcar nuclei and you will see myocyte disarray. Yeah, so wrongly I had told it in DCMP. It is what? HOCM, hypertrophic obstructive cardiomyopathy. HOCM. Autosomal dominant. Even ARDC is also what? Autosomal dominant condition. Because they are autosomal dominant, they have to be what? Screened for first degree relatives. In HOCM, what is the problem? There will be diastolic failure of the heart. Diastolic failure. And in this exercise leads to increased demand from the heart and decreased supply to the heart. This leads to MI, can lead to death also. That is why strenuous exercise is contraindicated. Yes, correct. Banana shaped ventricles will be there. Yes, we also call this myocyte disarray as helter-skelter myocyte. Correct? Yes. And they can have syncope, MI, death, all those things can be happening. Important. So that means death happens usually in athletes, those who do what? Severe exercise, strenuous exercises, isn't it? Yes. Then restrictive cardiomyopathy, nothing more. One, hemochromatosis. Hemochromatosis causes what? Initially, it will cause DCMP because iron will cause what? Death of the myocyte leading to DCMP. Later on, it can progress to RCMP. Most common will be what then? DCMP, because initially there will be death. Later on, fibrosis will happen and it can lead to RCMP. Yes. Other than that, in hemochromatosis, yes, let us discuss here only mutations. What mutations will cause? HFE, most common. Then HJV. This is a childhood onset. All others are what? Adult onset. Then TFR2 mutations. Clinical feature apart from cardiomyopathy, most commonly what? Cirrhosis will be there, correct? Cirrhosis. Then type 1 diabetes mellitus, hyperpigmented skin lesions, hyperpigmentation of skin due to increased melanin and hemosidrin. दोनों होते हैं यहाँ पे, increased melanin and hemosidrin. Difference between cardiac amyloidosis and restrictive cardiomyopathy on histopathology slide. Restrictive cardiomyopathy I cannot diagnose based on what? Biopsy. Restrictive cardiomyopathy will be based on what? The ejection fraction and other things. On biopsy, I can just see what? Fibrosis. In amyloidosis, I will see what? Amyloid. And amyloidosis causes restrictive cardiomyopathy. Okay. Yes, there can be, yes, correct, pancreatitis also. And that will lead to what? Malabsorption. Pancreatitis. Then, yes, orchitis also can be happening. Right? So, hemochromatosis. Next is in lungs. Very, very important in lungs will be carcinoma of lung. Lung carcinoma, yes, three important. Yes, sir. Which are those? Adeno, squamous cell, small cell. Adeno and squamous cell together are called what? Non-small as well, isn't it? Now, each one of them importance. Currently, most common overall is what? Adeno. Most common in India will be what? Squamous cell. Most aggressive is what? Small cell. Small cell is very rapidly proliferating. This is the one which is chemo sensitive also. Although it is very good chemo sensitive, but relapse occurs very quickly. Prognosis is poor. Smokers. Smoking can be associated with anything. Maximum smoking association, more than 99% of SCLC are seen in smokers. Meaning, if you are developing a small cell, that means you should be a smoker. Otherwise, you will not develop what? But however, incidence of small cell is rare. So, most common seen in smokers is squamous cell. Adeno also can have smoking history, but can be seen in non-smokers more predominantly. Adeno, peripheral location. Squamous, central location. This will also be central location. Because adeno is more centrally located, it will more commonly cause what? Hoarseness of voice. Or I can directly write RLN compression, recurrent laryngeal nerve compression, commonly seen here, isn't it? Next, in adeno, yes, butterfly or yes, lapidic pattern that will be seen in a subtype of adenoma called as bronchiolo-alveolar carcinoma. Bronchiolo-alveolar carcinoma. A subtype will show lapidic pattern. Right? Now, more important, markers. So, leave this lapidic pattern, not very important. Yes, markers पढ़ते हैं. ये क्वेश्चन आएगा आपको. Markers में napsin A is positive in what? Adeno. Napsin A. P40 and P63 are markers of what? P40, P63 are markers of squamous. Small cell chromogranin. Synaptophysin. Small cell is a neuroendocrine carcinoma, by the way, and CD56. These are markers of small cell. Okay. Yes. Napsin A. Now TTF1. TTF1 can be positive in adeno and in small cell, and usually negative in squamous, right? Yes. So these are the important markers. Now on histology, in small cell, you will see crushing artifact, and this is what we call azopardy effect or azopardy phenomenon, right? No, salt and pepper will not see small cell carcinoma. In carcinoid, you will see what? Salt and pepper. Okay. Mesothelioma, important biphasic tumor. Mesothelioma markers calretinine WT1. Two important markers you remember. Yes. So azopardy phenomena is nothing but DNA getting deposited in the blood vessel wall. That's it. Okay. Yes. So this is what is about your lung cancers. Lung cancers. Next, in kidney. So important in kidney glomerulonephritis. Okay. Predominantly nephritic which one? And predominantly nephrotic which one? Predominantly nephrotic minimal change disease, FSGS, MGN. Predominantly nephrotic. Predominantly nephritic will be which one? Salt and pepper will be seen in neuroendocrine tumors, but small cell carcinoma is a very high grade neuroendocrine. It would have lost that small salt and pepper appearance. Okay. Yeah. Predominantly nephritic, PSGN, IgA nephropathy, PSGN, IgA nephropathy, then lupus, then HSP, good pasture syndrome, Wagner's granuloma. Okay, I can write all together. All these are what? RP genes. RP gene will be predominantly what? Nephritic, isn't it? RP gene will be predominantly nephritic. Now, so in this, okay, few of them will be both. What is that? Both, which will be having both. MPGN will have both. Even MGN also can have both. Okay, MPGN will have both. Yeah, Burkitt will be AIDS defining because it's a high grade lymphoma. Burkitt is a high grade non-Hodgkin lymphoma. It will be AIDS defining. Now, RPGN, important in RPGN. What do you get in RPGN? On histopathological examination, on biopsy, you get what? Crescents. And we can divide RPGN into three types of RPGN. Tell me what are those? Type 1, type 2, and type 3. How do I differentiate? On IF. Type 1 will show linear deposits. Type 2 will show granular deposits. Type 3, no deposits. Type 3, no deposits. Now, type 1, linear deposits, causes good pasture syndrome. Type 2, lupus, HSP. Type 3, ANCA associated Wagner granulomatosis, MPAN, Churg-Strauss syndrome. Okay. Yes. And in this, only one which is type 2 is good pasture syndrome, which is a type 2 hypersensitivity here. Next, few important findings in kidney biopsy. Important finding in kidney biopsy, wire loop lesions कहाँ मिलेंगे? Lupus, especially type 4 or class 4. Class 4 lupus, wire loop lesion. Then next, subepithelial hump. Tell me, where do you get subepithelial? Subepithelial deposit you will get in what? PSGN. In PSGN we call them what? Subepithelial humps. Subepithelial deposits can also be seen in MGN. Subendothelial, where do you get? Subendothelial deposit, PSGN, MPGN, lupus, subendothelial deposits. Subendothelial deposit. Okay, MPGN type 1. Dense deposits, MPGN type 2. Also called as what? Dense deposit disease. Basket view appearance, where do you get? Alport, in Alport syndrome. Basket view. Effacement of food processes, where do you get? Effacement of food processes, where do I get? It will be seen in any nephrotic syndromes like what? Effacement of food processes will be seen in minimal change disease, FSGS, MGN, any nephrotic, not specific. Any nephrotic will show what? Effacement of food processes, isn't it? Yes. Next. Next is renal tumors as well. Okay, in renal tumors, important renal tumors, VHL mutation. VHL is located on 3P associated with what? CRCC. Dennis-Drash syndrome, familial we are talking, due to WT1 mutation, Dennis-Drash syndrome. Then WAGR syndrome is also WT1 mutation. Both of them are associated with what? Wilms tumor. One more, Beckwith-Wiedemann syndrome. And remember, Beckwith-Wiedemann is WT2 and is also associated with Wilms tumor. But WT2 is a proto-oncogene, whereas WT1 is a tumor suppressor gene. So there should be loss of function of what? WT1 to cause a tumor and gain of function of WT2 to cause what? Cancer here, isn't it? Yes. Next. Yeah, in Beckwith-Wiedemann, there is loss of maternal imprinting as a cause, or it could be due to what? Paternal disomy of chromosome 11, because this is located on chromosome 11. Most common primary renal malignancy, clear cell carcinoma, clear cell RCC. Next, in GIT, important in GIT, enteropathy, celiac disease. What will be the finding, biopsy finding? Villus atrophy, crypt hyperplasia. This will be in celiac and tropical sprue. Both will have same. Celiac and tropical sprue both will have what? Same finding. That is why difference between them will be what? Response to gluten. That is the important difference. Next, what will be the finding of A beta lipoproteinemia? A beta lipoproteinemia, lipid laden vacuoles in epithelial cells. A beta lipoproteinemia, lipid laden vacuoles in epithelial cell, and peripheral blood smear will show acanthocytes. Peripheral blood smear, acanthocytes. Then Whipple disease. Whipple disease, pass positive macrophages in lamina propria. Pass positive macrophage in lamina propria. Next, one more question. Polyps of intestine. Yes, I will try to show you different polyps. I will give you a schematic representation. Please tell me what polyp is what. Okay, the first polyp, look what am I showing here. There are dilated glands within the polyp. And this is a 5-year child. I am giving you history. 5-year dilated glands and some inflammation happening within the polyp. Some inflammation and ulceration. This is one. Second polyp, 10-year, and you are seeing the connective tissue is showing what? Branching like this, and in between you are seeing what? glands in between. Yes, sir. What will this be? These are the glands that are in between, and there is what? Connective tissue. What is this? Peutz-Jeghers polyp, correct? Or both of them are what? Hematomatous polyp. The first one is what? Juvenile polyp, juvenile rectal polyp, and this is Peutz-Jeghers polyp. Both of these are what? Hematomatous. Next, one more polyp. Look, polyp is like this, and there are branching glands seen. So within the polyp, you are seeing glands which are what? Branched like this. Look at this. When I say branching, meaning what? They will not have simple lumen. They will be having what? Complex lumen like this. Branching glands are seen. So tell me now, what are you thinking? What is this polyp? There is one more polyp which will have tall villi-like projection like this. Yes, correct. This is your tubular adenoma. This is your villus adenoma. Then one more polyp will be, yes, there are some villi and there are also what? Branching glands within this. Tell me now, what are you thinking this is? Yes, there are branching glands, complex branching glands. This is your what? Tubulovillus adenoma. Tubulovillus adenoma. Isn't it? Next, one more. Look at this. I am trying to show you. This is a villus adenoma. And the surface of the villus adenoma will show sawtooth appearance like this. Irregular cells will be there. Tell me now, what is this polyp? And expect this in exam for me. Yes, sir. Sawtooth appearance like this. Yeah, what is this sawtooth appearance? Where do you see? This is called sessile serrated adenoma. Very good. This is your sessile serrated adenoma. Tell me, where do you get this? Seen commonly in familial condition HNPCC. In HNPCC, we see what? Sessile serrated adenomas. Sessile serrated adenomas, right? Yes. So these were important topics from pathology. Yes, I had to concise the topics here. I don't want to discuss the whole class here, right? So, these were most important topics and most expected questions from pathology in your this year INICT. Best wishes all of you. Any doubts if you're having, quickly I can take few doubts. Don't ask me to teach a topic. Okay, any doubts if you're having, I can take. Tips for INICT. Don't leave any question and come. Apply logic and get an answer. Don't overthink. Keep thinking simple. That's it. What will be the first sign of MI on histopathological examination? Definitive sign, loss of nuclei. Otherwise, waviness of muscle fibers will be seen. But waviness is not a definitive sign of what? Death. Loss of nuclei, karyolysis, that will be the definitive sign. Okay. Okay, guys. Best wishes, all of you.